Welcome to our video series on how to be a good doctor. Today we'll be discussing part 3 of ECG interpretation. My name is Dr. Iresha Gunasinghe. I'm a cardiologist from California. So, my goal is to teach you how to confidently interpret a stat ECG soon after you graduate from med school. So, just to recap, it's very important you follow this protocol and it's very important you practice. So, the first thing you see when you get an ECG is look at the rate. Next, you look at the rhythm. Third, you look at the axis. And then you look at lead 2 and start looking at the different waveforms. We talked about the P, PR, and QRS. So just to recap, you know how to check the heart rate by counting the number of large squares. And remember, I wanted you to memorize this 300, 150, 100, 75, 60, 50. If the heart rate is irregular, then you count the QRS complexes in 6 seconds and then you multiply that by 10. Next, you make a decision about whether the rhythm is regular or irregular. Then you look at the axis and decide whether it's normal, left, or right axis. Then you go to lead 2 and evaluate the P wave. Is it normal? Is there right atrial enlargement or is there left atrial enlargement? Next, you look at the PR interval. Is it short, normal, or long? Next, you look at the QRS complex still in the lead 2. And if it is broad, that is more than 3, then you decide is there left or right bundle branch block. And for that, it's best to look at lead 1. And then you eyeball to see whether there is left ventricular hypertrophy. So that's where we stopped. Today we'll be discussing first the ST and then the T wave. Now, remember the ST, that is at the end of the S, you get the J point and then it's usually an isoelectric part, usually at the baseline. Now, three things can happen. It can stay at the baseline, or it can go up like this, or it can go down. If it goes up, that's an acute MI. So we call it ST elevation myocardial infarction or STEMI. And then if it goes down, it's usually ischemia, but the ischemia may be so bad that it can kill a few heart cells, myocardial cells, and then we call it a non-ST elevation MI or non-STEMI. But it could just mean ischemia as well. See, it goes down. Now, if it is a MI with ST elevations, it is well localized. What that means is that we can, just by looking at the ECG, know exactly where the MI is. But if there is ST depression, all we can know is that there is ischemia, but we wouldn't be able to pinpoint where the ischemia is. It's not sensitive. Now, let's dig a little deeper about the ST depression. So this is a normal, and then you see the ST is depressed here since this is the baseline. But you notice that it goes up and creates the T wave. So we call that an upsloping ST depression. On the other hand, here you see that it is parallel to the baseline, but it is at a lower level. So that kind of ST depression is called horizontal ST depression. And then you have the kind where it is downsloping. So that's called downsloping ST depressions. This is not too bad from a ischemic point of view. This is quite significant, and this is the worst kind. Okay, but they all denote levels of ischemia. Now let's talk about ST elevation MIs. At this point, I would like you to take a break if you are tired, because the rest of it is going to be a little bit harder. So first, let's remind ourselves about the coronary arteries. You have a left main artery that divides into two, and that's the left anterior descending artery and the circumflex artery. The left anterior descending artery supplies the septum and the anterior wall. The circumflex artery supplies the lateral wall, and then you have the right coronary artery. And remember, ST elevations means we can localize where the MI is. So we use our detectives to tell us where it is. And since we are first going to talk about the left anterior descending artery, if the left anterior descending artery, we have to look at this part, which is the V1 and V2. That if there is ST elevations in V1 and V2, that usually tells us that there is a MI of the septum. Then if you go further, that is V3 and V4, then we know that the anterior wall is also affected. If the ST elevations are seen in V5 and V6, then we call it a lateral wall MI, and that could be because the circumflex artery is affected. 1 and AVL also denotes the same area. So this is a very, very important slide, and you do have to memorize this. Once again, V1 and V2 indicates the septum. V3, V4 is the anterior wall. V5, V6 is the lateral wall, and 1 and AVL is also the lateral wall. Now this is a real ECG. Again, please, you have to go through the sequence when you are looking at ECG. Don't jump to the thing that looks abnormal. But just now, I'm just going to show what is abnormal. So if you look here, this is our baseline, and the ST should have been here, but it's not, it's up. So therefore, we call it ST elevation. And where do we see the ST elevations? We see it in V1, right? V2, V3, and V4. So this is the septum. This is the anterior wall, okay? The next part is, let's look at the right coronary artery. Now, the right coronary artery is a little bit more complex because it supplies all kinds of areas. So what are they? As it comes through the atrioventricular groove, it is going to supply the right ventricle. Next, it's going to supply the AV node and the posterior part of the septum, right? And this is the inferior wall. So there are many parts that it supplies, and for each one there is a ECG finding. Now the common thing we see is the inferior wall, and that we'll be looking at 2, 3 AVF. Okay, 2, 3 AVF. Look at that, 2, 3 AVF. Those are the guys that are looking at the inferior wall of the heart. And 2, 3 AVF, you will have ST elevations if there is a right coronary artery infarction. Here is a real example. So this is our baseline, and you see the ST is way up there, and you also see it's seen in 2, this is 3 and AVF. So we know immediately that it's a inferior wall MI. When we see an inferior wall MI, we have to ask several other questions. The first thing we have to ask is the right ventricle affected? Now, for that, this is where we traditionally place the ECGs. But now we do just the opposite and place them on the right side using the same landmarks. Like, V4R will be at the mid-clavicular line on the 5th intercostal space, but it'll be the 5th right intercostal space, okay? And V1 will become V2 and V1R and vice versa. So if you notice, there is a R. So it'll be V1R, V2R, so on and so forth. Now this is to check the right ventricle. Here is an example. Since the computer is not smart enough, usually we have to handwrite the letter R. Otherwise, later on, nobody would know that the leads were looking at the right side. So we call it a right-sided EKG. And you can see that there is ST elevation. So if you see V4R and there is ST elevations, then we know that the right ventricle is affected. And you will know later that this has a lot of management decisions that we have to do because of this. The next part that can get affected is, since the right coronary artery goes to the posterior septum, we have to find out, did the posterior wall also get affected? So for that, the traditional way we put the leads, well, we continue it on the back. And this is what we do. They are called V7, V8, V9, okay? So they are all at the same level of the V sets, but horizontally, this will be at the left posterior axillary line, and then at the tip of the left scapula, and then at the paraspinal area. So those are called V7, V8, and V9. And that's the way we check to see whether there is a posterior MI. So here is a real example. What happens is, when we do our normal traditional ECG, you can see that there is ST elevations here. So we know that there is a inferior wall MI. And then if you bring your eye to V2, you realize that there is a funny looking ST depressions in that. So since V2 is looking at the front of the posterior wall, it's really a mirror image, and it's really what it's trying to tell us is that there is ST elevations in the back. So that's another clue for you to put those additional leads and check the posterior wall. And if we actually did that, you will see this pattern, real ST elevations. Okay. Now I need to teach you another concept, and that is what happens to these ST elevations over initially hours, then days, and then weeks later. There is a story here. So the very first thing we see are ST elevations. And slowly but surely, you will start noticing that it starts coming down. And weeks later, you wouldn't even know that the patient had a MI. As that happens, the T wave starts inverting. And that happens like day 1 to 2 or so. But weeks later, even the T wave gets back to normal. Okay. The third thing that happens is a Q wave. As you notice, normally there is no Q wave. Remember, that's the first wave down, right? And then it becomes bigger and bigger and bigger. So weeks later, the only clue you will have is a big Q wave to say that the patient had an acute MI. Okay. Here is an example of that. See, there's a huge Q. Do you see that? That shows and that tells us that the patient has had a MI. It does not tell us when the patient had the MI. It might have been a few days or even few years. But Q waves, significant large Q waves like this, usually indicates an old MI. So now we learned a lot of things about the ST, and we'll end today by learning a little bit about the T wave. Again, the T wave normally is a nice looking little upright wave. You can see one here. With sometimes it inverts. Okay. For you at this level, if it inverts like this, it usually denotes ischemia. This is one thing you really need to know, because if you ignore it, a patient can die. And that is what we call peaked T waves. Okay. That indicates high potassium, or we call it hyperkalemia. Okay. Please don't miss this, because first thing that happens is it gets peaked, and if you ignore it, the PR interval starts getting longer, and then the P disappears, and then much later the QRS begins to widen, and finally you get this weird looking waveform, and then if you completely ignore that, the patient will die from high potassium. Okay, so it is very important for you to recognize this, and they are classic. Okay, they are peaked, so don't forget that. Well, that's all for today, and next time we will be discussing arrhythmias. So I want you to be the best doctor you can be and help people in need without expecting anything in return. And remember about the qualities of a good doctor. Thank you so much for listening, and I wish you the very best. And please do share this with your friends.